All right, let's also acknowledge that success can mean different things for different patients in different scenarios. For one patient, a successful swallowing therapy could lead to reduced risk of aspiration. Another client, the success could be measured in just that there's perhaps still aspiration there, but there's less aspiration. You could measure success by the degree to which a patient is able to sustain appropriate hydration and nutrition. Or in some extreme types of scenarios, you might have a situation where the patient success is just the patient staying alive. But this goes back to what we were saying earlier about you having different goals for different patients and tailoring your expectations to what the patient needs, what they want, and what is possible for them. Some usual ways that we show progress, improvement in a patient is using functional outcome measures. And this is basically just parameters that we can measure to show an improvement in the patient's ability to swallow, take food, or maybe their quality of life. So some common ones are is the amount of assistance required for eating. So if you can show the patient now needs less assistance to eat than they did before your therapy, that's an improvement. If you're able to show that you delivered education to the patient and the caregiver about their problem, about their swallowing problem and how to deal with it, then that is an improvement. If you can show that the patient now needs less time to take their meal than they did beforehand, that's an improvement. If you've been able to reduce their reliance on adaptive feeding equipment or put into place adaptive feeding equipment, that's an improvement. If you've been able to put into place compensatory strategies or maybe reduce their reliance on compensatory strategies, that's an improvement. If you've been able to increase their level of diet, then that is an improvement. If you've been able to do something to increase the patient's satisfaction with their ability to take food, or if you have done something that you can show improves the patient's quality of life, then that is a good way to show improvement. We use our raw data from therapy as outcome tracking measures. We use our baseline measures and our post-therapy or our data from the last therapy session to show an improvement there. But we also use some tracking tools to sort of pan out from the minutia of the data from the individual therapy sessions. I've already mentioned the SWAL-QUAL, which is the measurement of the patient's quality of life. You could also use other assessments like the Mann Assessment of Swallowability, Functional Oral Intake Scale, Dysphagia Outcome Severity Scale, Penetration Aspiration Scale, which rates their severity of penetration and aspiration. So if you could obviously score them as having less aspiration and penetration after therapy as before therapy, then that certainly is an improvement. So there's lots of different ways in which we're able to show improvement in the client from before therapy to after therapy. And that's a very important thing to do, because if you can't show that what you're doing is having a positive impact on the patient or improving their quality of life, then you really don't have then you're not going to have a strong rationale for doing what you're doing. During all therapies, therapy is constant reevaluation. You need to be always reevaluating the client, reassessing where their abilities are. You always need to be looking for new ideas for treatment. As the patient improves in one area, that may open up new venues for improvement in another area. So for instance, if cognition suddenly improves, then you may be able to implement behavioral strategies that you weren't able to do beforehand. So for rehab, for restorative therapies, the goal is to try to get them back to improve their ability, their physiological ability to swallow, to as close to normal as is possible. Another way of saying that is you want to minimize the presence of the dysphagia. And this might mean something different for different people. For a young, healthy individual, they may be able to come all the way back to normal pre-injury level functioning. For older individuals that maybe have more concomitant issues, you might just be trying to get them into the realm of functional PO intake with compensatory strategies present. So a lot of our restorative strategies fall into the realm of exercising weakened structures that aren't working appropriately to restore appropriate physiological function. So repetitive drill-based activities. So for you to implement these strategies, for you to implement these exercises, you have to be sure that the patient has an etiology that's going to respond appropriately to the exercises so that you know that they will be able to get better. So if they have like ALS, then doing the exercises is not going to help. It may make things worse. Same with MS. You want to be sure that they are cognitively able to do what you're asking them. I've had plenty of situations where family members are demanding restorative strategy and the patient doesn't have enough cognition to follow directions. If that patient cannot do what I'm asking him to do, he's not going to be able to participate in exercises to restore his ability. So they have to be cognitively able. And they have to be motivated to perform the exercises independently, repetitively, with enough sets of reps to have improvement when you're not around. So they have to be able to do these things when you're not around, because you're not going to be able to be there to cue all the sets of repetitions that each day that the patient needs to be able to do in order to improve. And this, to some degree, comes down to them having good caregivers, good support systems in place that are able to step in and do that. All right, so let's get into specifics here. A lot of what we're going to talk about is going to fall into the realm of strategies for hypertone, spasticity, and strategies for hypotone. So strategies for hypertonia and spasticity, generally you're wanting to relax the muscles, restore range of movement so that whatever it is can operate normally. If you're talking about hypotonia, you're not wanting to relax the muscles. They're already relaxed. They're too relaxed. You're wanting to stimulate them and strengthen them to bring them up to normal. So we come at hypertonia and hypotonia in very different ways. And you'll recall this dichotomy from motor speech as well. So let's start with the lips and work our way back. So for reduced labial seal or reduced labial closure, you need to be able to have a nice seal compression of the lips so that you don't have anterior spillage. And also, like if you're taking food off of a spoon or a fork, you are able to use your top lip to get the bolus off of the utensil. So if you have a patient with a weak labial seal, that's the outcome of the lips being too spastic and hypertonic. Then you're going to want to come at the lips and you want to be relaxing the lips. So slow range of motion stretching exercises. So you'll have a gloved hand. You're probably going to work on pulling the lips back, retracting the lips, having your gloved hand, pulling the lips out, and maybe just doing a slow range of motion stretch. You want to work on lateralizing the lips, going superior and inferior with them. So this is passive movement of the lips. The patient is not actively moving the lips. You've shown the patient how to do this. You or the patient is using their hand to slowly stretch the lips and do range of motion exercises to the lips. That's very different from your hypotonic patients. So you have a patient that has reduced labial closure, not from spasticity, but from flaccidity, from hypotonia, in which case you need to stimulate the lips, you need to wake them up, you need to strengthen them. So it's not about passive stretching exercises to relax the lips. It is about range of motion, strengthening, active exercises. So having the client pucker and smile. Also having the patient lateralize their lips one way or the other. Having the patient purse their lips against the resistance of a tongue depressor. Having the patient lateralize their lips against the resistance of a tongue depressor. Having the patient inflate their cheeks and maintain the seal of the lips against the pressure of you squeezing their cheeks. Another strategy is you can take a piece of candy, like a Lifesaver. You can put it on a string, and then you can have the patient hold the Lifesaver just inside their lips, and you can pull on it and have them maintain that labial seal to try to keep that candy in their mouth. So they're exercising the muscles of the lips against the resistance of the candy that you're trying to pull out. And the stronger they get, the smaller the piece of candy becomes. You could just simply work on them being able to hold air in their cheeks 10 seconds by 10 reps. Because to hold air in their cheeks, to do that, you have to maintain a strong labial seal. There's another exercise where you could take a piece of gauze and have the patient clasp that piece of gauze between their teeth with the gauze hanging out of their mouth, and then they have to, using their lips, pull that piece of gauze slowly into their mouth. And generally speaking, the more repetitions, the more sets of repetitions they can do, the faster they're going to get better. And usually it's not an issue of too many repetitions, because it takes a lot. It always takes more repetitions than people expect. More in our field, the problem with oral motor kinds of things is usually there being far too few repetitions. So example of a measurable short-term goal for this would be during oral ingestion of 1 level teaspoon of pudding, the patient will fully clear the pudding from the spoon with no more than trace residue at 90% max Q. So that's 9 out of 10 trials. The baseline of 3. So you're not measuring, are they completing the exercises, although you could do that as well, but what is the functional outcome of the exercises? Are you able to show that they're able to take food off of the spoon more effectively as the result of your labial exercises? All right, now let's get into reduced lingual control, rehab for that. So obviously, the ability to move the tongue is extremely important for mastication. You need to be able to use your tongue to form an appropriate bolus. You need to be able to use your tongue to prevent premature spillage back into the pharynx. You need to be able to use your tongue to clear out any oral stasis that may be hanging around. So if you have an individual with a spastic hypertonic tongue, then you're going to want to come at that tongue with an idea to relax the tongue to reduce the spasticity in the tongue. So once again, gentle, slow range of motion stretching. Now I emphasize the word slow because it's the slow range of motion stretching that reduces the stretch reflex, which is cueing the spasticity. Quick stretches increase the stretch reflex, which is going to increase spasticity. So for the tongue, using a gloved hand and a piece of gauze, reaching and grabbing, have the patient protrude their tongue and you reach and grab their tongue, the apex of their tongue with the gauze, and then simply providing slow range of motion stretches laterally with the tongue, up and down with the tongue. For your patients that have reduced lingual control due to flaccidity, hypotonia, then once again, you want to work on drill repetitive exercises to increase the strength of that structure, increase tonicity, and wake that tongue up. So protruding the tongue, retracting, side to side, elevating the tongue, pushing it down, doing these in a repetitive motion, ideally with resistance, but you can start without resistance. And essentially what this looks and sounds like is you saying to the patient, all right, do this for me. I want you to stick your tongue out. Okay, we're going to move it from side to side. 1, 2, 3, so on and so forth like that. And then you move to having a resistance where they're pushing against the tongue depressor, lateralizing their tongue against resistance, elevating their tongue against resistance, protruding their tongue against resistance. Another strategy is you could give a patient something to put in their mouth to work on bolus control. So for instance, you could take a piece of gauze, you could probably dip it in juice, something to make it a little bit more pleasant, just so you're not asking them to chew on raw gauze. Putting that piece of gauze in their mouth and having them work on chewing, masticating that gauze on one side of their mandible and then using their tongue to manipulate the gauze to the other side. And you could do this in various different ways, but however you're doing it, you need to be able to pull whatever it is that you're putting in their mouth out of their mouth and keep them from choking on it. So here is listed on the slide using a piece of licorice string, like a red vine or a Twizzlers. Now, yeah, that would work, but if they're at risk of aspirating any of those pieces that they chew off, then you want to consider not doing that. The smaller you make the thing that you're asking them to manipulate in their mouth, the more difficult it's going to be for them. So in the beginning, having a big wad of galls that they can chew, where it doesn't take a lot of motion to chew and control a big wad of galls, but the smaller that galls gets, the more range of motion it requires and the more dexterity of the tongue. After you have completed the previous goal of the patient being able to manipulate an object or some solid piece of food that you're putting in their mouth but you're maintaining control of, you can move to taking a solid or a liquid and creating a more paste-like consistency and having them practice chewing and moving that paste bolus around inside their mouth. And you could increase or decrease the difficulty level of this by increasing the size of the bolus, which will make it easier to manipulate, decreasing the size of the bolus, which will make it more difficult to manipulate, increasing the viscosity of the bolus, which will make it more easy to manipulate and keep together, keep cohesive, and decreasing the viscosity of the bolus to make it more difficult. And once again, you have to consider the patient's likelihood of posterior spillage and aspirating when you're doing these things. And oftentimes at the end, the patient can just spit it out. And if posterior spillage is really a concern, probably you're going to have the patient performing this activity with their head down like this, which will reduce the likelihood of that bolus, pieces of that bolus being able to get back into the pharynx. An exercise that you could use not to target necessarily bolus formation or manipulation, but AP transit, is you could take a piece of gauze and you could soak that gauze in juice, and placing the gauze on the tongue, you could have them move their tongue against their hard palate anterior to posteriorly to squeeze the juice, squeeze the liquid out of the gauze. And the more gauze you use, the easier that is. So difficulty can be increased by using less gauze, and difficulty can be increased by also using less liquid in the gauze to make it more difficult to squeeze out. Keeping in mind the safety of the patient, if you're putting a lot of liquid in their mouth, you have to keep in mind that you want to keep them safe and keep them from possibly aspirating that. If you have a patient that has reduced elevation of the velum, then that could be negatively affecting their swallow. They could be getting pieces of the bolus up into their nasal cavity during their swallow. If that is a hypotonic or a flaccid weakness, then you could work on strengthening the velum to be able to elevate, to seal off the velopharyngeal port appropriately during the swallow. Strategies for strengthening the hypotonic velum. for swallowing are similar to strengthening the hypotonic velum for speech. CPAP is going to be one of the main strategies. So you have a CPAP machine, that continuous positive airway pressure. So this is a machine that you put it on your nose and it's pushing air into your nasal cavity, which keeps the velum down. So when you try to elevate the velum to do something like nga, 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 to move it like that, you are elevating it against the resistance of the CPAP machine pushing air into the velum, which will strengthen the velum, which will allow you to have a better velopharyngeal seal during your production of non-nasal phonemes during speech and also during swallowing. You could also try some straw sucking tasks where you give the patient increasingly more difficult textures to try to suck up through the straw. And this is effective because in order to pull through a straw, the velopharyngeal port has to be closed. Otherwise, you're just going to be sucking air in through your nose. And there's always safety considerations for anything that gets into the patient's mouth that you have to worry about them aspirating. So in something like this, you could stop the activity before they're actually pulling the fluid into their mouth, so you don't have to worry about them aspirating any of the liquid that they're pulling through the straw.